social considerations, motivation for pregnancy, attendance at classes. The idea is that education will decrease your anxiety because you kind of know better what to expect. That's why we really want people to tour the unit. It's helpful to kind of know what the routine is. It's pretty upsetting for a patient who comes into labor and delivery and had no idea they were going to get an IV put in. And maybe that's not what they wanted. Did anybody have a birth plan yesterday with their patients? So some patients come in and they have a document and it's very explicit as to what things they want to have with their birth experience. So I think that is really important to kind of know what that is ahead of time. A lot of people feel very good about their labor partner, whether that's a spouse, boyfriend, girlfriend, their mother, their sister, their best friend. Some moms actually prefer not the father of the baby. They find support from someone else. And I think you might pick up some interesting group dynamics. It's really not the time to argue who owes rent to whom in the labor room. You know, it's just not a good labor environment. So the nurse has to intervene and be an advocate for the patient. Helping patients in terms of control of breathing. Patients often hyperventilate. Sometimes they're very anxious. You can kind of see it. I mean, their whole body is very tensed up. If you've got a chance, or I would encourage you just to kind of watch those very quick Lifetime videos. You can see visibly the anxiety in the patients and not in others, and just that it holds in their whole body. So anything that you can do to kind of alleviate that anxiety, help them with their breathing, distract them, talk about things, and you can just visibly see them relax to let the work of labor do what it needs to do. It is pain with a purpose. It's not just like a sprained ankle. It's helping bring your baby into the world. It's helpful that hopefully you are with a healthcare provider that has the same philosophy that you have in regards of care. So for example, if you're with a particular provider who does not, they don't like their patients to have anesthesia, and you really want an epidural, you don't really want to find that out in active labor at the hospital. It's better to have those conversations ahead of time. So if you know the cause of labor, you would be the mega millionaire. Okay, we don't really know what causes the trigger of labor, but we have some theories. One of them is that the placenta stops making progesterone, and so we see a decline in that hormone, and that actually causes contractions to occur. The other thing is prostaglandins. And so again, maybe the trade-off is that the proportion of hormones changes, and so there's always prostaglandins present, but because of the shift in maybe progesterone and prostaglandin, with more prostaglandins, it causes the softening of the cervix. It also increases, again, muscular contraction. When we encourage women a lot of times who are post-dates to have sex, because there's prostaglandins in semen. And so prostaglandins can sometimes stimulate contractions to occur. The other thing is when you're sexually active, you stimulate the breast, which causes the endogenous release of oxytocin, which would cause contractions as well. And then this corticotropin releasing hormone, again, that's something else in terms of looking at the body understands that it's a stressor. We see changes in the hematology of the patient, so the white blood cell increases, kind of knowing that, yep, I'm getting ready for this big stressor. I have all these compensatory mechanisms in place, and now is the time to have a baby. But a lot of times we just don't know. And so when people ask, how do I know I'm in labor? We're going to talk about these premonitory signs of labor. Now, on this list, there is something on here that I'm very fussy about. I don't like it. And so of the things that are up here, when I think of premonitory, I think of as impending signs of labor, okay? And the thing that I'm the fussiest about on this list is rupture of membranes. And the reason why I'm fussy about that is because when you read about this in the book, it kind of makes it sound like, well, labor still might be 12 to 24 hours away, and it could be a little while. And in my experience, when the water breaks, we really would like the patient to go ahead and go on to the birthing suite, labor and delivery, because when the water breaks, we have to be cautious about a couple things. One is to make sure that there's not cord compression, that we don't have a prolapsed cord, we don't have variable D cells. But the other big thing, and you have to remember, my lens is color, it's rose color because of my experience, because of high risk, is group B strep. when the water breaks, we really want to get those antibiotics on board before she delivers. If the water breaks and it's meconium, there's some things that we need to monitor with the baby on that. So the other things, I'm kind of like, yeah, I mean, like, to me, lightning and ruptured membranes, those are two completely different things. Because like lightning, what lightning is when the baby gets engaged down the pelvis, and mom's like, oh, I can breathe now, I feel better. Well, gosh, that could happen a week before you have the baby. I don't go to labor and delivery, whoa, I can breathe now. That's not a reason to go to labor and delivery. Even with contractions and even cervical change, contractions have to be there. They have to be regular for cervical change and effacement to occur. And we're kind of ruthless in labor and delivery. We don't really like to keep folks who are in that latent phase or the early phase of labor. I tend to use the word latent. So you have latent phase, active phase, and transition. We really want to try to keep people more when they're in that active phase, because you can kind of do that latent stuff at home. You get to eat what you want, you get to go to the bathroom, you're not tied up to a bunch of different things. If you're low risk, you can really do most of that at home. All right, so we talked about bloody show. When I say bloody show, I'm not talking bright red blood, I'm not talking clots. It's kind of brown, wine-colored, mucusy, nasty, bleh. Okay. Now sometimes patients have bloody show after a vaginal exam, after intercourse. So if a patient comes into triage and says, I've been having bloody show, I'm 38 weeks. Okay, well, if you were just seen at the doctor yesterday and they did an exam, that bloody show just may be from the exam. Are you having any contractions? Well, I've had 3. Okay, we can put you on the monitor, make sure you have a reactive NST, but we're probably gonna send you home because I don't think you're really in labor. That's different than our patient who's been contracting every 5 minutes for 1 to 2 hours. She's having to breathe through those contractions. She can't talk through them. She's noticed a change in pelvic pressure. She's very uncomfortable. That's more telling that the patient is truly in labor and more than likely active phase of labor. Sudden burst of energy. So I think on this list, I would just be cautious about what things are wait and see versus what things would be, yes, you need to go to the hospital. So to me, if you're having not Braxton Hicks contractions, but regularly pattern contractions, they're lasting close to a minute, they're 5 minutes apart or less, they've been that way for an hour or 2, you have a change in vaginal discharge, you have a change in pressure, that's a sign to go to the hospital. But just because you have Braxton Hicks is not a sign to go to the hospital. So the word intermittent, because you have to be careful how we use that word. When I think of Braxton Hicks, I think of intermittent, but I also think of mild. So the intensity is very low. Some women do not even know they're having Braxton Hicks contractions. So in other words, you might have a patient who's on the monitor and it shows a contraction, but if you ask her, she's like, well, I felt a little cramping, but I wouldn't really call it a contraction. That would be a Braxton Hicks. So yes, those would be intermittent. Now labor contractions should also be intermittent, but they are much higher intensity. Does that make sense?
So we would want to follow up if it just said no contractions, still follow up.
Yes, so the other thing in labor and delivery, sometimes we use this term called irritability, uterine irritability. It looks kind of wave-like at the bottom. So it's not these really nice hills, it's just kind of, and it's just kind of like, again, kind of like the heart, it quivers, it's just not coordinated enough to really do anything. So I would want more information than intermittent, okay? Sudden burst of energy, so you hear about nesting, everybody wants to, because it's kind of like it's time the baby's gonna be coming, I wanna have everything ready. Weight loss of 1 to 3 pounds. So right at the end, sometimes women's appetite changes, they feel less hungry, they don't feel like eating things. The other thing is we start to see some fluid shifting occur. So again, it doesn't necessarily mean that they're nutritionally deficient or anything. Backache, vaginal pressure, and then this change in GI symptoms can often be attributed to, again, the prostaglandins that are being released. Some women, unfortunately, they didn't have any nausea and vomiting since the beginning of pregnancy, but here at the tail end, they're feeling really queasy. So that's when women are starting to have these early labor symptoms, it's really important. We don't want them to be NPO because you need energy, because labor expends a lot of energy. Mild foods, avoid things that would trigger nausea and vomiting, small amounts of clear liquids, And, if you do get sick and throw up, that could sometimes move things, that sometimes is a sign things are moving along, so I wouldn't stay home. I don't know, don't wanna scare y'all, but I've actually seen somebody like vomit her baby out. That was horrible. It's not a way to bring a baby in the world. She was so sick to her stomach and just could not stop throwing up. And the baby was crowning and whoop, out the baby came. So, 'cause again, the same interthoracic pressure to push down on the baby, so couldn't control it. All right, this slide I feel like does a little bit better job for you distinguishing between true labor and false labor, okay? So on the left, these are all true labor. On the right, these are false labor. Now, false labor, I'm not sure I would ever tell a woman she's having false labor. Because some women find that really offensive, because this can be uncomfortable, but the issue is that it's not quite labor enough to stay in the hospital. So I would use the term early labor, and it may or may not continue, it may actually stop, okay? But generally, when we see these types of changes occur, that's a sign that labor is occurring and we're moving toward delivery. And again, for some women, it's a very long day, some women, it's a very short day. If you're having your first baby, you never know. Sometimes first babies take a long time, sometimes first babies take a short time. You just don't know. All right, there are a ton of numbers on this slide. And I think what I would ask is that try to apply the information rather than memorize the numbers on this slide, because there's a lot of interpretation, okay? So the latent phase, 0 to 3 centimeters, right at the beginning of labor. It's a very long phase, it's a very easy phase of labor. She's smiling, she's talkative. A lot of times moms are doing this at home, but here's where I think students get mixed up. You can be dilated but not in labor. So you have a G4P3. She's 2 centimeters in the office, but if she's not contracting, we're not gonna monitor, we're not gonna tell her to take off work, we're not gonna tell her to change what she's doing at all. Because she might be able to still take care of her kids, be at home and work. There's no reason to just sit there and kind of wait. It's like trying to watch water boil. So unless you're having contractions, there's not really any sign there of labor. The contractions, again, 3 to 30 minutes, so that means that you may only be having, it's variable, and you might have contractions 3.5 hours, you might have 5.5 hours. But notice again, the duration very short, and they palpate mild to moderate. Active phase tends to be above 4 centimeters. Now, some of our facilities, they have different criteria. So you might be at a labor and delivery unit that says 3 centimeters is their criteria. I totally get that, okay? But with active phase, that's where things, it's a more active time. You see a change in the patient's demeanor. Contractions are closer together, and they're longer in duration, and they're higher in intensity, okay? I'll say that one more time. The contractions are closer together, they're longer in duration, and they're higher in intensity. And remember, with intensity, we're doing that by palpation. So this often, this is where we can see sometimes like the water breaking on its own. Patients, ideally we want to get patients kind of admitted in this active phase to the hospital, so that way we can kind of get all of our prep work ready and anticipate labor. Transition phase, it is the shortest phase of labor, but it is the hardest phase of labor. So with transition, very unpredictable, you can rapidly progress. So you might be 8 centimeters and then a half hour later be complete and ready to have the baby. Kind of sounds like that's kind of what happened to your patient. She came in and they put her in bed and boom, it was like, okay, there's the baby. One of the things that for me as a labor nurse, if I have a patient whose bag of water is intact at transition, kind of want to try and keep it intact because it provides a cushion. So it kind of helps control things a little bit. It helps mom cope with the contractions because the contractions are very painful here. They're very close together and they're very longer. So notice here, 60 to 90 seconds. I used to do this in class. So what I would encourage you to do at home is to put an ice cube in your hand for 60 to 90 seconds to simulate contractions. Because you think, oh, that's really not that long, 60 to 90 seconds. But if you've ever had a whole ice cube in your hand for 60 seconds, it's pretty darn uncomfortable. And so I think it's that idea of having to mimic that, and it happens, and you get a break. But notice our contractions are 1.5 to 1.5 minutes apart. So if you have a contraction that's 1.5 minutes apart and it lasts a minute, you really don't have much time between contractions. So it's a very difficult phase, and that's where, you know, Hollywood likes to make fun of people yelling and screaming and doing all kinds of crazy behaviors in transition. Second stage, mom often likes this better because she can do something with that pain. And again, you'll see some people now are saying, especially with a multip, in transition, sometimes they have the patient try and do a sample push, and that cervix is so floppy that the patient's actually able to kind of push past. The reason we don't want people to push when they're in transition phase is if the cervix is not floppy, they'll actually tear the cervix as they deliver the baby, and that has some long-term consequences, and it is super painful. So we really don't want patients to push while there's still cervix there. But in the second stage, she's completely dilated. The baby's in usually a positive station, so +1 or greater. The contractions continue, but now you have not only involuntary power, but voluntary power. So first time moms, sometimes they need some help pushing because they're not really sure where they're pushing. The other thing is if you have an epidural or any kind of anesthesia, that affects where you're pushing. Multips usually will push better and faster. Patients without epidurals sometimes will push faster. It just kind of depends on the station of the baby, the size of the baby, how effective mom is at pushing. Sometimes patients, they actually turn the epidural off so that mom pushes better. So she pushes better because she has better sensation, but she also has the return of pain with contractions. Okay, so it's not like, oh, I'm just pushing, there's no, I'm gonna come back to this transition phase, this difficult pain, pressure, that sort of thing, okay? And then laboring down, I'm in the second stage, cervix is completely dilated, but the contractions are doing things, but I'm not doing any voluntary pushing with that. So sometimes what you'll see is they might do a trial push. Let's see how you do. We'll have you maybe try and push, and if the baby's kind of high, seems like mom's kind of tired, then we let her rest. So when would be some situations we would not labor down? The baby's in distress, okay? So in other words, the baby's showing us signs that it's hypoxic. So you see tachycardia, bradycardia, you see late decels, you see absent variability. We would not just sit there and watch that and let her labor down. If mom is running a temp, so we're concerned about infection. You know, she's running a fever of 100, 101, 102. And then the other thing would be if there's any other complication like bleeding, if she has any significant risk factors, that again puts her at risk for the time of delivery. But those are probably the most common things are fetal distress and mom. So these are the same links to the videos I showed you. One shows a patient getting an epidural, another one shows a natural childbirth. So I would encourage you to take a peek at those. All right. Cardinal movements of labor, it's kind of like fetal circulation. I think people get really obsessive compulsive about it. At best, there will be one question about it. So it's a 2-point question. It's like the cranial nerves. So you have a little acronym that you kind of put in your head to remember the movements of labor. So engagement often occurs prior to labor, descent of the baby through. Notice that you have the flexion of the baby, and so what's happening again is as that baby's coming through, you have this flexion of everything in. There's internal rotation, and actually what happens is that the body is often in one position and the head actually twists. So notice that internal rotation happens before external rotation. When the baby's head gets delivered, the baby's often looking toward maternal spine because that's occiput anterior. So when the baby, if I'm in bed, the baby comes out like this, looking down. And then what will happen is, again, you'll kind of see that external rotation occur. And the shoulders get in alignment. And then usually what happens is you deliver the anterior shoulder first and then the posterior shoulder, and then the baby comes out. Okay. So it's kind of amazing to think about kind of all the movements that the baby has to do through mom's pelvis to kind of be kind of expulsion to get finally out. When the baby's head is out, you often will see the provider kind of take their finger, kind of put their finger there in the mouth, and then they usually will do a little bit of suctioning there. Not always, if the baby seems to be doing okay. And it almost looks like they're pulling on the baby's head. I don't know if you guys noticed that yesterday, but they're not really, they're just kind of easing the shoulders. For some of our patients, we have to be really concerned because if the baby's large and has really broad shoulders, we're concerned about a condition called shoulder dystocia. So a lot of people think it's the head is the most difficult part to deliver, but it can actually be the shoulders that can be a little tricky. So here's one example. Every darn fool in Egypt really eats raw eggs, but I've given you a little video here. And so again, it's just, I think if you kind of remember that external rotation occurs after internal rotation, I think you got it. Neonatal resuscitation. So folks who were on the delivery team. APGARs yesterday? APGARs for your babies? What were they?
Well, one was 8.
Okay.
8.
8 and 8?
8, I'm sorry, 8 and a 9.
8 and a 9.
1 minute was 8 and then in 5 minutes it was 9.
Okay.
The other one was like 4.
Oh,
Yeah, it was pretty sick. We had to walk away to the NICU.
Oh. Was it early?
No, those ones all in Filmium and all.
Oh,
Had
and
any.
precipitous and kind of out of control.
Yeah, she didn't really have any prenatal care to
Oh,
speak of that
goodness.
much.
Oh.
8th kid. We
Oh.
spoke her and just
Oh.
a lot of kids.
Ooh. 8 to 9?
Yeah, pretty much.
Okay.
I got shoulder dystocia on the last one.
Okay.
That was kind of crazy.
And do you know how long it was between the head and the shoulders coming out?
Like time was,
Like approximately?
they
minute?
said, like, I watched him, like, immediately, like, go to the episiotomy, like,
Yeah.
right away. I was
Yeah.
like, whoa, that happened so quick. He's like,
Yeah.
alright, we're doing this.
Yeah.
And snipped
Did you
it.
see anything in the baby at all?
What do you mean? Like, oh, yeah, we did
The
like an
arm didn't
assessment.
move, or
Did
you had
you
any
have any fractures?
crepitus or anything like that in the shoulder?
No, we were checking for that. That's what
Okay.
he was worried
Well,
about.
that's good. Yeah, because sometimes you have to fracture, again, a fractured clavicle is better than a
Right.
hypoxic or brain damage baby. So, yeah. Somebody else had, was it APGARs? They were all 8. Okay. I heard nobody say 10. We're very stingy, right? Everybody, like their moms, why did my baby get a 10? Well, we usually take off for color. That's the most common thing that we take, because we tend to see acrocyanosis. To get a full 10, it's pink all over. So 8s and 9s are pretty common. And it's funny as a student, because you'll go and you're like, okay, I don't know what they marked off for. So when you go and you talk to the staff, they're like, color. They're very laissez-faire about it. And you're like, but I want to know exactly what. So you just have to kind of roll with it. Again, you have to realize they do this a lot. And you're like, I didn't really see them count the heart rate. Did they, how did that happen? And a lot of times, again, your baby's pink and crying and screaming. So I don't think it's a 4. I have a lot of data there that says my baby's doing okay. The other thing is some babies go directly from the table to the warmer, and some babies go directly to mom's chest. And so as long as the APGARs are nice and high, we can usually have the baby go right to mom's chest. If baby needs more resuscitation, we don't want to do that on mom's chest, we're going to take the baby over to the warmer and do more things there, okay? And so you saw things like drying the baby off, stimulating the baby, yes, okay, bulb syringe. So that's your most common resuscitation. So in terms of this, the only thing I want to kind of stress is, in terms of bag and mask, we really only do that if the heart rate is below 100, okay? So positive pressure ventilation, and that's with bag and mask, which you did as part of CPR as a healthcare provider many moons ago. Actually, I think it was like 8 months ago. But it's only if the heart rate is, but we don't give a lot of supplemental oxygen to new babies. It's pretty rare that we do that now. The other thing I want to stress to you is we don't give a lot of medications to babies for resuscitation, okay? So all those fun code drugs that you talked about, maybe in pharmacology, or maybe critical care, we don't really use a whole lot of those. So when you look at this and you kind of get way down here before you get into like epinephrine and stuff, okay? The other thing is on my, did anybody do, like, probably on your baby that had Apgar 4, did you put was the baby on the pulse oximeter? Did you see that at all?
Oh, yes, her little oxygen was like 50.
Okay.
52, and her heart rate was coming up. But she had to have that, and she was just grunting, she was so full of meconium in her lungs, and they had to suction her quite a bit. And she went right, quick, hello to mom didn't even get to hold her, she went to a little NICU basket, and off we went, just the doctor's hands in there, tending to her while we got her there.
So one of the reasons I bring that up is it takes a little bit of time for new babies, pulse oxes to get up to what we would consider in adult land to be normal, okay? So if you'll notice there's a little graphic here at 1 minute, I think it's 60 to 65, 2 minutes 65 to 75. Now I don't know about you, but if I had a pulse ox on an adult at 65%, I would be a little nervous about that. But the reason why it just takes some time to have that transition from fetal circulation to neonatal circulation. But that's one of the things in talking about neonatal resuscitation is looking at the pulse ox and then also looking at EKG to get an accurate count on the heart rate, because if you have a sick baby, the concern is that you're not counting the heart rate accurately because you're so distressed, and it's like this babies that are sick, they're blue, they're floppy, they don't respond, they're not crying. It's very distressing to be at a birth and there's no noise. I mean, even little preterm babies, little 32-weekers, they cry. And I mean, they sometimes, and you really hear them, and that's actually a good sign. We want babies crying, so we don't want to say, shh, don't cry, don't cry. Crying is a good thing because it clears out all those secretions out of your airway. Okay. So again, just some subtle differences here. Please do not worry about some of the details on here. It's more of a FYI. So for example, logic, I'm going to use a different size ET tube for a premature baby than a term baby. And so you'll notice on some of your equipment that's by the warmer, it's right there. I don't have to have anybody go and get it. I have a lot of different sizes, so that way if the baby needs to be intubated, it can be done pretty rapidly. And then Mr. SOPA is an acronym that is used in neonatal resuscitation. One of the key things in terms of ventilation of new babies, a lot of it has to do with repositioning. And again, clearing the airway, because what's the most common problem is all those secretions. So when you have that nasty thick meconium, it doesn't help to bag you if I can't get the air in, so I gotta get those secretions out. Okay. Some change in practice. So we used to do a lot of vigorous suctioning of babies who had meconium, and we're doing less and less of that now. It just depends on how nasty the meconium is, how thick it is, when it occurs. But we used to whisk babies away, so like baby would deliver, even if the baby was screaming its head off, we used to take the baby over to the warmer, and that the NICU team or resuscitation team had to visualize the vocal cords. And we don't do that anymore. If the baby's active and no distress, there's no need to do that. Okay. Nurse-assisted birth, that can happen. There are some places, if as a labor and delivery nurse, they actually want you to do some deliveries on your own in orientation. So that way the physician will be there, but they actually want you to do it so that you know how to do it correctly. It's usually okay with the patient and the physician, but it is part of your training, so that way you know what to do. The big thing is that we don't want to leave moms alone. So if somebody comes in and the head is crowning, you need to stay there, get other people to get the pre-sit pack. And so the pre-sit pack has everything you need, has blankets, bulb syringe, it has clamps, it has scissors. It's things, again, for an immediate resuscitation of a baby. Stay very calm. We want the patient to blow and not push. It's really important, again, if you can, to clean the perineum as best you can, and control delivery of the head. So if we can, we want to try to get her into the bed. Sometimes patients refuse. They are standing. And so literally you will see nurses on their knees catching the baby as mom is standing and helping assist, because we don't want the baby to fall on the floor. Everything's wet. It can be kind of chaotic. We're watching for the cord. We don't want mom to fall. So it's a lot of safety issues. It takes a lot of help, but I think it's an emergency situation. But in general, most of the time, we have good outcomes, because again, labor has gone so quickly that the baby comes out and everything's kind of done. So we can't get an IV started, but our goal is, to make sure we got a healthy mom and a healthy baby. Okay. So this is kind of showing you as the head is delivering, you apply some counter traction there to ease the head out. The head should not pop out, and that's one of the reasons I don't have you all push your ping pong ball out of your uterus, because it'll pop out, and that is the opposite. So that would be a bad precipitous nurse-assisted delivery. It should ease out, because again, it needs to stretch to avoid tearing. And again, we're watching the baby carefully to make sure there's not a cord around the head. So when you take your fingers around the neck, and so sometimes you'll hear about a nuchal cord. We have to reduce that nuchal cord. So you loop the cord around the baby's head. Sometimes there's a tight nuchal cord. If somebody, and again, generally with a nurse-assisted delivery, this doesn't happen. But if there's a tight nuchal cord, there may be a situation in which you actually have to clamp the cord, cut between, but then you've cut the baby's lifeline, so you have to get the baby out. And again, it doesn't generally happen in this situation. It just happens kind of, all comes out. Patients will deliver in triage. Some patients deliver, I will never forget, patient did not utter one sound, not one sound. And you pulled back the treat, it was like, it was a no prenatal care patient, and pulled back, and there she is. Her face is beet red, and the baby's head is right. I mean, it's just like, oh my gosh, I will never ever forget it. And the worst thing about that, she said, take her away, full term, big baby, where I'm gonna give the baby up for adoption. My husband doesn't even know I'm here. He thought, I just told him I just gained a bunch of weight. And so she wouldn't hold her or anything. It was the most sad day for me. One of the most sad days I had in labor and delivery. She had hidden it from everybody. Like, she didn't go to the doctor, didn't do anything. She didn't want anybody to know. But she had 3 other kids at home. Husband was unemployed, and she didn't have me to take care of that baby. So, whew. So we delivered the baby, everybody, she was fine, and the baby, beautiful, healthy, no problems at all with the baby. Apgars were 8 and 9. After the baby is delivered, we generally do spontaneous delivery of the placenta. And so the difference with that is we don't do that early express, okay? In the hospital, you see early express. So they massage and they're given a little gentle traction on the cord. The reason that we don't really want to do that is if I accidentally pull on the cord too hard, then you can get retained placenta up in the uterus and cause all kinds of complications. If you were out in the community, what I would probably do is have the baby go up to mom's chest. I might have mom nurse the baby to have that release of oxytocin to help the uterus contract. When the placenta delivers, we need to massage very firmly and get that uterus clamped down. Okay. And then with Pitocin, remember that Pitocin, you see it given IV. After delivery, we bolus it in. We're not worried about water intoxication. It's like, okay? So we bolus it in, but her bleeding should stop pretty quickly. If I don't have an IV site, I can give it IM. Okay? So I can give 10 units of Pitocin IM, and again, it works pretty quickly. Third stage of labor, the placenta separates away. You'll see a gush of blood. And we want to look at the placenta. I heard that several of you guys got to look at placentas and kind of see, so it's kind of nice to see both sides and see different pieces of it and kind of give you a picture of what happened with labor. We want to make sure that it's intact, so all the cotyledons are there, so the placenta's intact. We talk about the cord insertion, whether it's central or eccentric, or whether it's off on the side, because you can have different problems with the placenta there. And then it's during the third stage of labor that the repair of the episiotomy or laceration occurs. Manual removal of the placenta is normal and expected for C-section. It is not normal and expected for vaginal deliveries. So manual is normal on C-sections. Vaginal delivery, high risk, lots of complications, potentially. And then the fourth stage of labor is about the first 4 hours after birth, the blood loss. So everybody who delivered yesterday, you had EBL on your documentation. And what do you remember your EBL being? 200, 800. It's kind of all over the place. I don't hear anything over 1,000. Okay. So again, the advice on this is changing just a little bit, but again, the more blood loss you have, the more concerned. We really should not be having over 1,000 milliliter blood loss. So tend to have more blood loss with C-sections. We do vital signs every 15 minutes, we check the fundus every 15 minutes, and then we put ice on her perineum. We wanna make sure the bladder's empty, cause that puts you at risk for hemorrhage. We wait to make sure sensation returns back to her extremities before we try to ambulate her. Pain is a big issue, so you wanna keep her pain under control. Make sure she's bonding with the baby, she's often relieved, and that this kangaroo care. Now again, you don't have to breastfeed to do kangaroo care. Just put the baby up on your chest, keep the baby, you're the best warmer for the baby, pretty much skin to skin. Okay. Breastfeeding is great too, but if you don't wanna breastfeed, you can still do kangaroo care. Dads, partners can do kangaroo care too, it's not just moms who can do kangaroo care. All right, I'm gonna stop there.